It's clearing a lot of points, and the points we probably are not dealt with very well during our presentations. So there's a nice case today about lateral condyle. We're going to have lateral condyle next week. Taral will take it, and then we'll discuss which are the cases where we can treat conservatively. Probably today was the case where, which is little bit uncommon, and this is the perfect case where you can take conservative treatment for lateral condyle. Otherwise, a conservative treatment for lateral condyle is little less common compared to operative treatment. It is not the case with today's presentation. I will be more focusing on how to get a conservative treatment in children with both bone forearm. Will show that it's not very, I mean, you cannot go scot-free just by keeping operating good for it. Hi, welcome, Shita. Good morning.
Hey, good morning. Good morning, everyone.
Let's all welcome Sheetal Parekh, who could have joined midweek because it was midweek session. So now we'll most likely be having all the sessions so that we'll have it on weekend so that everybody can join. It seems weekdays people join much faster than weekend. So weekend hangover starting from Saturday evening is little too early. Lockdown seems to have changed the timings.
Sir, any comparison between screw and K-wire for lateral condyle, sir?
So I think we have, we'll discuss that next week. Screw, I think Sandeep already suggested that if you have a non-union, then screw is much better, or a delayed union. I think that case you showed was a 3 weeks old, probably going for delayed union or non-union. So in those cases, screw treatment is better. But if you have a fresh fracture, I think there is a wide open debate whether you will use screw or wire. Both has its own advantage and disadvantage. I think next week we'll cover that. But basically, if you are using K-wires, you will be able to avoid second surgery. You can just plug them out in OPD and the second surgery is not there. But then in those cases, there will be a little higher radial, there is a higher bump or the lateral spur is slightly higher. If you use screw, that lateral bump will be smaller. You will be able to, get a little bit compression, which may not be necessary in the fresh cases, but you will require an additional procedure to take that screw out. So, which way you want to use, you need to be judiciously doing that. Sheetal, any comments on this from your side?
Yeah, you're correct that for non-union or for delayed presentation, screw gives better compression. But for a fresh case, there is a more trend to use a screw compared to K-wires nowadays. So we would use K-wires typically for a younger patient, like a child is 3 or 4 years of age and the fracture is not too displaced. We would end up using K-wires since the healing is faster. So we can remove the K-wires maybe around 4 or 5 weeks. But for a little bit older patient and for a displaced fracture, we are using a screw. The downside of using a screw is that you would need a second surgery to remove it. So you have to put the patient under anesthesia again to remove the screw versus K-wires, you can pull them out at the clinic, so you avoid a second surgery. The downside of K-wire, of course, is you may have to retain it a little bit longer, especially in older patients where it takes a little bit longer to heal. And one thing about lateral condyle is you want to allow it to heal before you pull out the K-wires because there can be late movement if the fracture is not completely healed compared to a supracondylar, which is, when you see early callus, it's not going to get displaced. So you can pull out K-wires at 3 or 4 weeks. So keeping the K-wires longer can lead to pin track infection and other issues. Older patient where you think it's going to take longer to heal and displace, like type 3 fractures, which are completely displaced, we tend to use screws more often. And younger patients with type 2, where we think that it's going to heal faster, we have been using K-wires. But the trend is to shift towards screws because of better compression and less rates of pin track issues and non-union.
I think it's already 6:39, so I think we should start.
Yes, we can start.
So, so let's start with today's topic. There's an announcement which I have already made. We are going to have audience poll in this. So immediately once you get the question, immediately start typing in your um, uh, chat boxes, right? Give me a second and then we'll. Okay, so today we are going to discuss forearm fractures in children. The only thing about forearm fracture in children is that the operative treatment of forearm fractures is very similar to adult treatment. Like if you see, you don't have if you have a proximal humerus fracture, at the most you will put conservatively put a K wire. If it's a supracondylar, you'll put a K wire, which you don't do in adults. If it's a radial neck fracture, you will reduce and you will put a nail from below. That you will not do in adults. In distal radius, it's roughly same, but forearm fracture is the one where operative treatment is very similar to adults. But that is where the difference that simile ends and the difference begins, that majority of the times you may be able to treat the fractures in children conservatively, and that's where my focus topic will be. So let's first start with a story. As always, storytelling is the ancient art of India, and once you listen to a story, you will be convinced in a much better way. So let's hear a story. This is a 2-year-old male, and this is the fracture you are going to get. So how will you treat this? There are 4 options we have. Start putting your answers in. Start putting your answers here. Okay, we have 2 answers: B, C, D. I have a taker for D, C, D, D, B, C. Okay. So the answer D. Let us see what can happen. So this child had nailing, and um, what do you think? It's done well, and this is how it united. And this is what happened. After 8 years, child presented to me with um, uh, this deformity. So now my question is, this is how the child had the X-ray. So what went wrong? Again, we can have an answer. No, I'm sorry, I'm getting ready because with my screen share, I am unable to see the chat. Right. Ashok, can you help me? How can I see the chat when simultaneously?
Yeah, that's a difficult thing.
Okay. Because I am not able to see. Can you just guide me what is happening with others? Or Taral, can you guide me with the answers? So that
I will do that.
yeah. So that the flow remains. Let me know which is the most common answer.
Common answer is D. Can't tell why.
Okay, I think I think that's a very nice answer, because I also couldn't say that why this happened. And when I examined him, I found that the child had an open. See, this is the story which happens more often than not, that you take the child in operation theater for nailing. You may get the reduction of one of the bones, which is easier to fix, and you don't get the reduction of the second bone. So you will have to open it. Sometimes, in developing countries like ours, parents don't tell you exactly the time of injury. You don't know how much interval it has passed since the injury. So once you do an open reduction, which you are forced to do, you don't have a choice at that point of time. The child has anesthesia. that things can go wrong. Like this paper from Journal of Pediatric Orthopedics B, where they studied ulnar non-union and found that majority of the ulnar patient had been open. So one thing you need to notice that whenever you do an open reduction in children, there are definitely chances that that fracture can go for non-union. The second paper, one of the largest series of forearm non-union bone from Dr. Di Gennaro, who is a very leading pediatric orthopedic surgeon in Risol Institute of Italy, where they again studied the non-union of radius and ulna. And if you look at my highlighted cases, almost 90% of their cases had either open reduction, some circulage, or some form of disturbance with the healing hematoma. So, when there is an increase in operative forearm fracture treatment in children, we need to look back at how we can get away with this. I definitely understand that there is parental demand nowadays, which is increased over operative treatment. People want to go back to their routine faster. They don't want plaster. The plaster technique, again, it's losing its value. Even in my teaching institute, where I give a lot of plasters, my residents are not interested in learning that. The thing is that if the X's are not looking very good post-operatively, then you will require a lot of explanation. You need to spend time with the parents. And of course, our patients don't pay for conservative treatment. And that is why, but this makes one of the background reasons where we opt for more operative treatment compared to other times. So let's start with what is the basics of pediatric forearm fractures. So by default, there are basically three possibilities which can happen. One is plastic deformation, another is a green stick fracture, and third is the complete fracture. So let's start with plastic deformation. So this 4-year male fell from a slide, and you can see that there was a significant deformity in the forearm. But if you look at here, the ulna was a green stick fracture and radius did not have a fracture. And this type of fracture is only seen in children where their osteons are pretty elastic and it allows a lot of bending before it breaks. So the first, generally it is plastic deformation. When one cortex breaks, the another rotates on that, which becomes a green stick, and once that cortex breaks, you get a complete fracture. So true angulation was somewhat like this. So how can you get away with this? Is you have to manipulate over under general anesthesia over a soft but large roll, so that and a continuous pressure needs to be given. Right. Once you do that, you will get a fairly good correction. 100% correction may not be possible, as you see in this slide. This angulation is not getting 100%. But if you get it within the range of less than about 10 to 15 degree, as I mentioned in my paper in remodeling, you will be able to get away.
Can I make a comment, Premal, here? I also want Sheetal to comment on this. That if you have one bone plastic deformation, one bone green stick, moment you correct the plastic deformation, it's very difficult to get a good looking reduction of the green stick fracture. It almost you end up completely cracking it, and you get some alignment, but not perfect as seen on this X-ray also. So is this a common experience, Sheetal? Do you feel this happens?
Yeah, I think you would if both are green stick, then it's easy. It's a more of a rotational deformity, and you can derotate or provide 3-point molding and can maintain reduction. But when there is bowing involved and there is green stick, it would frequently fracture. The green stick would become a complete fracture when you try to reduce. The only difference in our technique, or at least my technique of correcting bowing, is to put sustained pressure over a rigid object rather than a soft thing, because it takes more force to correct bowing, and it takes sustained pressure. It takes about, it always feels more, but probably it will take a couple of minutes or maybe 3 or 4 minutes of pressure over a rigid fulcrum. And then the other thing we have to understand, if you don't correct it, bowing does not remodel, okay? Because bowing has no fracture. So if you think that a fracture that's 20 degree angulated is going to remodel in a 4-year-old, you're correct. But if you think that bowing is going to remodel, it would not. So bowing, if it's excessive, if it's causing a deformity, and if it's encroaching the interosseous space, you need to correct bowing when you see it. It's always better to correct it when it's fresh because of the plastic deformation, because late, once it is completely healed, then it is very difficult. You'll have to almost do an osteotomy to correct it if there is an issue.
One more question to both Premal and Sheetal is the plastic deformation. Many times once you correct, it looks good on the X-ray. Does part of it will rebound back? Does it come back? Some part of the angulation come back, or should you overcorrect it, or you just correct it and it would stay in a well molded plaster?
So
overcorrection, I haven't been able to achieve overcorrection. Sheetal, your response.
yeah, it's almost impossible to achieve not impossible, it's very difficult to achieve overcorrection, but that is why you need sustained pressure, because if you let it go once it's corrected, it would spring back. But if you keep it pushed for a while, then it would lose that plasticity. You would be able to overcome it. But you are correct that if you just correct it, it can correct just within a few seconds once you apply the pressure. But as you let it go, it would rebound into more into the same position. That's why giving sustained pressure over a period of time, and you check it once you are done. You let go your force, and you check it, and it should stay there. If not, then you need to continue putting pressure on it. There was a question about whether you can do an osteoclasis. Osteoclasis is done when you have a callus. In bowing, there is no osteoclasis. So either you correct it by gentle pressure or you do an osteotomy if needed. I've not done an osteotomy for an acute bowing, so you would be able to get it. It's difficult, but you would be able to get the correction. And the criteria for accepting a little bit of bowing is that there is no visible deformity and you have full thrown up forearm rotation. So in anesthesia, you can check. If a little bit of bowing is left, but clinically the arm looks straight and you can prone it and supine it without restriction, then that should be enough. So even if there is 10 or 15 degrees of bowing left and you can't correct it, you shouldn't jump on to do a osteotomy. So there is a little bit of acceptable criteria there as well, more clinical rather than based on angulation.
One more question is, while correcting bowing, if you iatrogenically fracture it, I've never done it. It's difficult to fracture a plastic deformation.
I think it's very important that we say that this is not a very common injury, and sometimes patient present pretty late. So I've seen at least in my practice, I've seen about 10, almost 30-40% came after 4 to 5 days. Where it is absolutely difficult to correct that. Unless and until patient comes to you really fresh, then you can do it, and that's not a very common occurrence in our practice. And
so how did you correct it? Then did you do osteotomy or did you try to close reduce it?
No, they don't. I don't have longer follow-up on that. So, but many times it comes after 7, 8, 10 days. Then they are absolutely not tender. And then taking them under GA and not producing the result which is desired is something which I have never attempted.
Yeah, I mean, I've seen iatrogenic fractures happens frequently with the green stick. When you try to reduce it, you will hear this small crack, and I'm not too bothered about it. I would not intentionally crack the bone to correct it, but it happens when you try to reduce it. You would create a complete fracture out of green stick. So I'm not too bothered about it. A complete fracture actually produces more callus than a green stick fracture. The more callus prevents a refracture.
That will come in couple of slides.
Okay. Yeah.
Okay, so this is how this ended. There was some residual angulation as Taral has suggested. I wasn't, I didn't want to convert this plastic deformation into complete fracture. So we expected that it is about less than 10 degrees. This is at healing, shows a reasonably good alignment. And if you look at it 1 month, here's almost.
Premal, if you go back, it's the classical sign you see. The green stick has healed with callus.
Yes, absolutely.
Whereas there is no callus formation where plastic deformation.
Yeah, you don't expect any callus. Yes, you don't expect, because this is not a true fracture. Actually, what happens here is there is a multiple areas of micro fractures, and that is how it bends. Okay. Right, so I think when you are cutting a wooden log and you want to make it round, then you have to make a multiple small cut with one cortex, one side of the wooden log intact. That is how you can bend the wooden log. Very similar happens, and this happens only in really young children. I haven't seen any child beyond 5 years with plastic deformation. Any other experience, Saral or Sheetal?
No, I've seen plastic deformation in older kids as well. Even 11 or 12-year-old, I've seen it. But the principles don't change. If I can get a straight limb and good rotation, then I would accept a little bit of plastic deformation. But if it's impeding rotation, I would tend to correct it in the OR.
So let's move on to green stick. As a green stick fracture suggests, green stick is when you have a green branch of a bone or of a tree. If you twist it, what will happen is it will break at one point. Other part of that green stick will remain intact, and that stick will rotate on itself. That is what happens here also. So the 7-year male fell while playing, and this is how the fracture was. What will you do? It's not very painful now, and it's a fresh fracture. What is the option of treatment? You will just apply plaster on OPD basis. You
Delegates can put the options in the chat box. We see B's and C's. B I think equal as C.
Fantastic. I think that is B would be the B and C both are correct, but I think part of the answer is already Sheetal has given. What happened was this child was treated on OPD basis with slight pressure and above elbow clasp in neutral position, and this is how it healed. It healed with a bump on the backside of the forearm where there are no muscles, and the deformity looks somewhat like this for foreseeable time, and then parents won't be happy. So how can we get it correct? So basically, as I've already said, that it's a fracture of either 2 or 3 cortices of the bone, but one cortex is always intact, and that is where the displacement is always goes in the rotation, and there is no displacement, cortical contact is always there. It's more stable than complete fracture, and one should remember this is a rotation injury. As Sheet has already given us a clue, there are multiple controversies. One is how will you reduce? Will you manipulate or not? Will you give anesthesia or not? Will you immobilize in neutral position, or according to our old principle that upper third should be in supination, middle third should be neutral, and lower third should be in pronation, and whether you will break the periosteal hinge or not, as Sheet already explained. So let's look at another clinical example. This is again a fracture at the distal end of radius, where the deformity is polar regulation. This child again in immediate post-op was immobilized in pronation, because this is a distal third forearm fracture. And after a few days, she was immobilized in supination, and after a few days, her X-ray was exactly looking like her preoperative X-ray. So what went wrong? To know what went wrong, we need to classify this fracture into 2 different varieties. The first variety is according to the direction of the deformity or the deforming force. First is the supination injury, in which the apex of the fracture is volar. This is called as a supination apex volar injury. Another is pronation injury, where the apex of the fracture is on the dorsal side. So when you have this type of injury, what you need to do, here you can easily see that the apex of the injury is on the volar side, and as the X-ray you see is the apex of the injury is on the volar side. So this is basically a supination injury where the apex is volar. So you treat it by applying plaster in pronation. So once you pronate it, most likely you will not see any fracture line, and the alignment will come along without doing anything. This is the child's body of all. Similarly, this is an apex dorsal injury, which is a pronation injury. You need to immobilize in supination, and you take the X-ray, and this is how it appears. I think we had a discussion on very similar looking X-ray, which was shown by Sandeep, I think, yesterday. And that is again was similar type of injury, but in an older kid, it may be a good idea to just get a good relaxation in supination and pin it in that position. So this is at a final healing. So now, as we have already discussed, whether the fracture should be completed or not. So often when you're reducing, as Sheetal mentioned, that you will hear a crack and the intact cortex will break. But then you cannot do anything about it. You have to go. The argument is that you should do it or not. Argument for doing it is that once you break that callus, as you have seen in previous case, that while correcting the radial bow, I ended up breaking the ulna. With that, you have got strong, very nice callus formation, and that healing is definitely much better than you will get otherwise. Another argument against it is that if you have make it complete, then there is a once you complete it, there is a less chance of recurrent deformity. But once you complete it, it can become destabilized, it can angulate, and you may have require a remanipulation. So there is a comparison done way back in 1976 by David and Green, where they used the rotational approach and reported 10% re-angulation rate in green stick fracture. But when they completed the fracture, the reported risk of re-angulation was 25%, more than double. So if you can get away without breaking the cortex, it is theoretically better, but there is not a huge difference between these two. And you must remember that we did a study with one of my postgraduates, and we found that almost 90% of the patients had apex volar injury. That means it was a supination injury, and children required plaster in pronation. This child, again, you can easily see that there is an apex dorsal injury. This is how the child had an X-ray. In supination, everything corrected. Small angulation was remaining. So you can leave it that way, but you can easily correct it. Once corrected, it becomes absolutely straight. And this is her 5 months follow-up with full range of movement and good alignment. Again, 12-year male, you can still have a green stick injury.
Can you go back 2 slides on that one more slide? So this is a good X-ray for those who want to learn that the radial bow is restored here. There is good interosseous space. So this is what you are aiming for when you're doing close reductions. Doesn't matter if you cannot derotate it. You can. There are other ways of reduction. But what you want is an interosseous mold. It's really important when you put a cast on. And the reason to have an interosseous mold is to maintain the interosseous space. So no, this is a good X-ray. I just want them to look at it and appreciate the interosseous space on the AP view and the radial bow, which is the normal radial bow, to be restored. This should be the aim. The ulna can be a little bit more straight or could be straighter, but the radius looks really good. So if you can maintain the interosseous space, you're not going to have issues down the road. So it's a good way of identifying the reduction. Even if there is mild translation or angulation in a young kid, it would be okay as long as bow is maintained and interosseous space is maintained.
So, I just wanted to ask one question to both Sheetal and Premal. That, Premal, you spoke about this rotational correction and the rule that dorsal angulation will be pronation deformity and should be casted in supination. But sometimes it really doesn't work. You get one angulation and you try to give, the corrective rotation, and it doesn't appear good on CM. So finally, the way I found it is you check under CM, and whichever rotation, either mid-prone, supination, or pronation, gives you the best interosseous spread and radial bow and straight ulna and good alignment. I accept that as a position and give plaster in that position.
Yeah, ultimately, I think we'll come to what are the criteria to select reduction, and then we'll see that all this criteria, if you meet, then whatever position it remains. The only thing is that if you maintain in a rotated position, the chances of redisplacement are less. On table, you will be able to get it very easily, but if you have a corrected rotation, then chances of redisplacement really becomes less. I think that is what happened in Sandeep's case also, and all these cases where the rotation was not correct or given in weak prone, I've seen it rotating. Of course, that angulation may not be that significant someplace to correct. You need extra explanation to bear it.
One more question is, are green sticks more prone to refractures?
We'll come to that. We have a case on that, so we'll discuss.
All right, we'll wait for that.
So this was a 12-year-old male and had a fracture, which was radius was green stick and ulna was complete with mild displacement. One of my residents tried giving back slab in pronation. It didn't work. So this is the classical X-ray. I think Sheetal would say that this is not a good thing to accept at this age. And this is probably somewhere in between green stick and complete fracture. That is what I think Sandeep calls as a double cortex green stick fracture. And this is where it's not good to go ahead and do your rotation treatment. And at 12 years, it may be a reasonably good idea to go ahead and do your nailing. And I think the same point is shown by, discussed by Sheetal, that they've got a nice intraosseous plate, alignment is good. And if you note here that I have not used 10 nail, it's a simple 12-inch K wire, the cost of which is about 40-50 rupees.
Yeah, can you go back to that X-ray? So these are good principles for nailing. Is that the radial nail should be a curved nail? You can see on the top one, so that it can maintain the bow, and the ulna nail is a straight nail. So if you don't curve the ulna nail, it's fine. That you can just insert the straight nail in the ulna because it's straighter, and the radius has to be curved. This is a good technique for nailing. You can always criticize all X-rays, but overall, interosseous space is maintained, radial bow is maintained. The tip is out on the proximal radius, which is not a big deal. But, right, not a big thing, but it's just that when you are abutting the ulna, you are creating some injury there in the proximal joint, radial nerve joint. Not a big thing, but you just have to keep that in mind. But the reduction is really good. Bending of the nail is important. Sometimes with titanium nails, no matter how you bend it, it takes the shape of the bone. So you may bend it the way you want it, but it might lose the bow once you are putting the nail through. But overall, while inserting, it's a good point. It's a good learning point to keep the ulnar nail straight and bend the radius nail.
Thank you. So when you get the green stick fracture next time, do not do it on OPD basis. Do not reduce, but derotate it. Remember the rule of Ifics. Check the remaining angulation. You may correct it on table so that the nature has to do less. If you by chance break the cortex, don't worry about it and give a nice well-molded plaster so that it does not displace. And you must follow up till it is properly healed, as Taralis said, that there are high chances of refracture in this patients because it does not give you excellent callus unless it is a completed fracture. So there's a very nice paper regarding how to check mal reduction in a radial shaft green stick fracture. So if the radius and ulna alignment is good, then in pronation the radius crosses over ulna in upper third. If it is in a neutral position, radius crosses ulna in distal part of the middle third or lower third. And if it is in supination, it does not cross ulna at all. So this type of mal rotation, because you're given plaster in rotation, this will be useful. So this is an apex volar injury. This child was treated in a plaster with this alignment. Ulna could have been a little better. But if you see that crossover, the crossover is perfect here. And this is how the healing has taken place. He gained full movement. And if you look at here, the ulna and radius are in line for from upper third to lower third. So this is an imperfect crossover. And this paper will share on WhatsApp group. You can go through this, and this applies only to green stick fracture, and don't extend this science used for complete fracture. Sheetal, your comment on this paper? This is one of its such papers. Only I think series of about 7-8 cases from Charles Price.
Yeah, the paper is good, but practically it's difficult to use it. The reason is that once you put a plaster on, or once you position the arm in a certain way and you think it's reduced, then it's very difficult for you to get the X-rays that you need. If you go back to their X-rays, they had a perfect AP of the elbow, and then you look at the position of the wrist. But once it's immobilized, you don't. It's very difficult to, once you're casted, say at 90 degrees of elbow, to get perfect views the ones that you want. Like here, you see in the middle X-ray, your elbow is in an AP view. But if you look on the other X-rays, so say for example the first X-ray, it's difficult to know the position of the elbow. But on the second X-ray, both of them are oblique. There is an oblique of the elbow. There is an oblique of the wrist. So when you have obliquities, then those signs don't work. You're talking about crossover. They would be only if the elbow is in a perfect AP view, and then you can see where the crossover is. But when you might have difficulty in getting those views. So practically, it might become difficult to use these.
Yeah, so I think unless you can supervise this X-ray, it's very difficult to get those X-rays. I completely agree with you. So if you have a clinic like I have, you can go in the second room and take an X-ray and come back. That's an easy thing for. I think quite a few of our fellows would also have similar situation. I think in your department it would be difficult where you order an X-ray, you will get it after a while, and maybe patient may not be around at that time. So that's a great thing. So there are certain things which is possible in our setup, and this is one just paper. You can just read. It's not a very big series. It's a series of about 8 cases, but it is something interesting. So going to the complete fractures. So this is a 6-year-old male, and this is the injury film. How would you treat?
People are typing in.
Yeah.
I think B and A's are most common answers.
Anybody for nailing? Nobody?
Nobody. No C's. I can't see any C's.
Okay. So I think our friend Atul Bhaskar has written a paper in which they did nailing of the more displaced bone, or fixation of a more displaced bone. There were plates and nails both. That was written in, I think, the late 90s. And they have shown good results, and the redisplacement rate of the second bone was very less. So that is why I've given the fourth option, single bone. So I think that's a perfectly good answer. And this is the post-reduction X-ray. And I want your comments now.
Most of the comments are A's and B's.
A's and B's. Okay. Okay. So let's look at is it absolutely good or not very good? Let's look at this. So we know that when there's a complete fracture, there are muscle forces at play. In upper third, the muscle forces which are there in the proximal radius is the most important is bicep, which supinates the proximal fragment, and that is why we tend to put proximal third fractures in supination. In distal third, the distal fragment is pronated by pronator teres, and in distal fragment it is pronator quadratus which pronates the fragment, and it is the brachioradialis which pulls the distal radius proximally, leading to shortening if there is an angulation like this. That is why we tend to put complete fractures of distal radius into pronation. Another important anatomy is radiological anatomy when you are dealing with analyzing the X-ray post-reduction. If you look at in anteroposterior radiographic projection, the radius, you need to look at two things. One is bicipital tuberosity, another is radial styloid. The bicipital tuberosity and radial styloid in perfectly AP X-ray of intact forearm are at 180 degrees to each other. And in the same X-ray, if you look at the ulna, the coronoid process of the ulna is seen in the lateral X-ray as same as the styloid of the ulna. So both of them are again at 180 degrees. That is why they are visible in the same X-ray. If you look at this X-ray, you see that here the radial tuberosity is seen, though the child is young, so you don't see a very full-fledged radial tuberosity, but you don't see any radial styloid in that X-ray. In the other X-ray, you see the radial styloid well, but you don't see radial tuberosity. When this child had X-ray in supination, now you can see that radial tuberosity is well aligned, and in the same X-ray you can see both of them together. And in lateral X-ray you can not see radial tuberosity, and you cannot see the radial styloid. This is now established 180 degrees. So that was about 40 to 50 degree malrotation in previous X-ray. This is a 2 weeks post-removal films, and is a 9-month follow-up. Sheetal, your comments on this?
Yeah, so there is conflicting literature in the sense that, say, for example, you have a volar apex green stick fracture in the proximal third of the forearm. Then, as per the rotational theory, because it's apex volar, you want to rotate and you want to put it, in pronation. But as per the theory of the level of fracture, you want to supinate it because it's in the proximal part. So there is conflicting theories. So my overall take is, and then it's also difficult to assess this, you're pointing out the right things about how to assess rotation, but about 30 degrees of malunion in rotation is tolerated very well in the forearm. Beyond that, of course, you don't want it. If you put most of these fractures with a good mold in a neutral position, you don't have to worry too much about the rotational aspect. They would fall, in line, because even if you're off a little bit, as I said, 30 degrees is an acceptable rotational malunion rate. So for most of the shaft fractures, I like to put the position of mid neutral position. That means neither supination nor pronation, and have a good cast with the good cast index and a good interosseous mold. And most fractures, most means I would say more than 90% of them would do well. And when you're checking under fluoro, if you're not happy with it, then you can try one of the theories that we talked about, putting it in supination or pronation. Of those two theories, I think the green stick rotational theory is much better rather than the level of the fracture theory, where proximal ones you would supinate and the distal ones you would pronate. I have not practiced it, and I've spoken with a lot of colleagues, and it's a good paper and a good theory, but not a very practical one, just because of opposing, different theories of how rotation works as well. So if I have to reduce a green stick, same thing, I would put it in a neutral position, press it, just give an interosseous mold and check it. And if I'm not really happy, then I would use one of the rotation maneuvers for the pronation or supination based on where the apex is. But I have not gone with the level of fracture. Now, it is typically seen like more proximal fractures do well in supination, like a Montagia. So there, you can, in proximal, little bit proximal third fractures, which are the most difficult fractures to control, are proximal 1/3 fractures. So in that case, you can try to check it under supination, and if it works, you can put it in supination. One of the reasons that the proximal third fractures are difficult to control is not just based on how you're reducing it, but just it's difficult to have a hold on it, because the musculature in the proximal forearm is much more, and your cast is not going to be fitting perfectly around the bones, whereas distally, you don't have much musculature, so your cast is going to be a well-fitting cast and you have good hold. So no matter what you do, you have to keep a close watch when you're close reducing these fractures, So the idea is that when you have proximal third fractures, your threshold to intervene and do a nailing is much less compared to middle and distal third fractures, because you can hold them well. So we are, especially for those who are above 10 years of age, we have been trying, we always try close reduction first, but our threshold is much less to put a nail in for proximal third fractures. So just my kind of view overall on these fracture based on level.
So I think it's a very, let me just clarify here two things, that the level theory applies only on complete fractures, and rotation theory applies only in green stick fractures. So you cannot overlap these and that.
But a lot of times, Premal, when you're treating green stick fractures, as I said, even if you don't want to fracture it, they would complete. They would, you would hear a crack.
It happens.
So then what do? Do you still maintain that rotational theory, or you go with the level theory? In my take is that if you put them in neutral position, most of them would align well. So you don't have to worry about having a rotational deformity more than 30 degrees, because that is not going to remodel. See, things where things are going to remodel, we can take a little bit of a chance that, okay, I would accept a little bit of angulation, I would accept translation, but what you don't want to accept is mild rotation more than 30 degrees, because that would not remodel. So that is where, you tend to compromise on some of these principles in order to allow remodeling to affect your angulation and translation, but not have a rotational deformity. And the chances of having a rotational deformity are much more when you put the forearm in full supination or full pronation. So unless you're absolutely sure and the X-ray looks perfect, then that's fine. But otherwise, if you have to err and you're not really sure about where the rotation is, if you put it in a neutral position, it's very unlikely that you would get a rotational malunion.
Yeah, precisely. So I think, I just wanted to clarify that you cannot use any rotational principle when the fracture is complete, and you cannot use this biceps relaxation, pronator teres relaxation does not apply in green. So I think it may be next time you get a case of green stick, just try and derotate that fracture under anesthesia and see how it works. I was really surprised when first time I did it after Dr. K. Wilkins started maybe about 20 years back. So as Sheeta mentioned, so whenever you get a fracture of a forearm, the most important thing is you need to remember mnemonic rod. At the bow of the radius should be good, whether you have operated that kid or if you are treating it conservatively. The bow of the radius is very important because you have to consider that bow of the radius is one of the intra-articular alignments, if you can say that, because both bone forearm are connected at top and bottom with two joints, but in between they are also connected to each other with an interosseous membrane. So whenever the interosseous space goes down, you're likely to have problem in rotation. So that's why your bow of the radius in whichever way you can maintain is very important. Rotation, I think we have already discussed with great detail and precision. Overlap is not a big deal as far as it is acceptable or both the bones are in similar overlap. Angulation are criteria. I have already shared a paper with you. You can go and check what are the angulation criteria which are acceptable according to the age. And displacement is not a problem as long as the alignment is good. Displacement, which I mean is translation, is not something which will remodel very well, provided the angulation is within the acceptable range. Rotation is well corrected and bow of the radius is maintained. Anything from your side, Taral, Sheetal, to add to this?
There was one green stick fracture that you did show initially. I don't know if you can go back. That's the most difficult fracture, not a green stick, but a complete fracture of the metadiaphyseal junction of the radius. So that is one of the most difficult fractures that I find in the practice. That what are we going to do?
I think the one which Sandeep also shared 2 days back, the distal dimetaphyseal one you're talking about.
Yeah, those fractures are very difficult. So I'd like to know the opinion what people would. You had an X-ray in the green stick fracture. You had an X-ray, though it was green stick. You can we can see what would everyone do if it was complete.
Okay, I'll have to then go. It was in another presentation.
If you can go up a little bit. Yeah, go back.
I think there's one more beyond this. I think you're talking about this one.
Yeah, the one before. Yeah, this one. Yeah, this one. So I would like to know if this is a complete fracture, okay, or imagine that this is a complete fracture and it's unstable or displaced. How would you fix this fracture? I've always struggled with this at this level. Would you put a nail? Would you put K-wires? Would you put plate? And all are correct answers. I just want to know what everyone's preferences are. If this is a complete fracture, displaced, and it's not stable, and you have to fix it, how would you fix it?
I think my preference would be K-wire if I can get away, because this is quite a narrow area. So I understand the trajectory is very difficult to get it. So sometimes, I recently had a case in which I put a K-wire, but the K-wire was coming out from here. it was not very stable. So I then put a K-wire from here to here, making like a cross K-wiring, one coming from top, one coming from bottom, the bottom lateral to medial and upper from here to here, so that I could spare the physis. Sometimes if it is slightly distal, you can get away with a nice one single broad thick K-wire, and that generally does the purpose. Of course, then you need to add a well-molded cast to this. So I think there was a paper which was discussed in Ifics Jaipur, where there was a Chinese paper where you can bend the K-wire at 90 degree and then take an entry from here and then do an intramedullary nailing. But I don't think I have any experience on that. Taral, can you share your experience with that? I don't know. Where is Taral? Taral, can you hear us? Yes, Sheetal, what will you do then?
I've done everything. So I've used intrafocal K-wires if the fracture is not too displaced. I've used cross. The issue with pinning is that no matter how many pins you put, it always behaves as one pin because they would all cross at the fracture site is so narrow. So whether one pin is sufficient because it may fall even after pinning. And then some of my colleagues have put a very small plate, like just a 2-hole or sometimes a 4-hole plate. I think that's also an okay option in this level here. You do a volar approach and put a small plate. We're talking about a little bit older kids, not younger ones, but after 8 to 10 years of age. So a plate is also a good option. I like to try with the K-wire first, and I'm if I have to use a nail, I would go with probably a dorsal entry. I don't use dorsal entry nails. I always use radial entry. But dorsal entry may give you a little bit more length on it compared to a radial entry, where you have to come a little bit lower. So I have tried it all different ways.
Sheetal, any experience with transfacial nailing? Because I've read a paper from Japan. It's a big series. They have put a K-wire through the physis percutaneously, keep it there for a couple of weeks, and then bring it out. Those wires.
No, I have no experience with transfacial nailing. Let me just share my screen, and if you can stop sharing I'll just show a few things. Okay. So just one thing is that I don't know if you can see my screen here.
Yeah, we can see.
So these are the criteria for kids who are less than 10 and less than 8 years old is 10, 15, 20. So the more distal you go, the more angulation you can accept. Because proximal third injuries would lead to more, if there is a malunion in the proximal aspect, it would lead to more restriction in motion compared to a malunion in the distal aspect. You don't accept anything more than 10 degrees of angulation in someone who is more than 10 years of age. The reason that
full screen with your slide.
Sorry.
You want to?
Well, I'm just going to choose a few of the slides. I don't want to go over the entire presentation. So one of the reasons why a proximal third fracture would cause more restricted motion is because of this. You see that your ulna is relatively straight, and the radius is what goes around, like in this arc when you do a full supination to pronation. So when you have a radius malunion, so this is a normal arc of motion as seen on the left side. But when you have a proximal third malunion and then you rotate it, you can see that your motion is only going to be this much. As your malunion goes more distal, you're going to get more motion. If you go further distal, you'll get almost complete motion, which means that more proximal your deformity is, the more restricted your motion is going to be. So that's why the threshold of accepting malunion is less for proximal fractures, because it leads to more restricted motion compared to distal fractures. So I just want everyone to understand that. As far as the cast is concerned, there are, it's under our control how to put a cast on. When you have so many gaps at different areas here, then of course the cast is not doing its job. And this is a very common deformity where the ulna starts to sag, the radius gets pulled, leads to a loss of radial bow, and the interosseous space is compromised. So an ideal cast is something where you put a pressure like this and you convert a circular cast into an oval cast with more pressure A to P. And this is a good cast where you have a straight ulnar border where you can see that there is no significant space between the cast and the skin. So the padding is minimal. And when you put the forearm, when you do the casting for forearm, put the forearm in the position, or put the elbow in the position which is the final position, and then start with your casting. If you have two people, that's even better. Let one person hold the reduction, one person apply the cast. But if you are just by yourself and you're doing it, just make sure that you don't just apply the cast and then you flex the elbow a little bit more. Otherwise, you would create a wrinkle here and it would go into the skin and would cause issues. So make sure that you have a final position before you start putting a cast on. Another way of doing it, if you don't have help, is to put a short arm cast and then extend it to a long arm cast. But if you have help, that's great. You can just do it all in one. Just a couple of points I'll make with this here. That if you look at these series of X-rays, so this is the initial X-ray, and then there is a reduction, which is pretty acceptable. But then at 2 weeks, this is what the X-ray showed. So most of us would then, go ahead with nailing because this is lost reduction. He is more than 10 years of age. This is not acceptable angulation. So what are your options? Your options are, reduce it and nail it. But one other option is at 2 weeks, if you take the patient back to the OR and reduce it, there are a few advantages. One is that the swelling is much less. So you can you can put a really good cast at that time. You do a re-reduction. You have some soft callus that has already formed, which means the fracture is sticky. So when you reduce the fracture, the alignment would stay because it's already a callus is there. So at around, between 1 and 2 weeks, if you have to re-reduce it, that means a second reduction, it is not completely essential that you have to nail it. We have a series, this series that we published had more than 30 patients that we have treated just with re-reduction, so without nailing, and we did not have any issues with that. So that's an option that you can re-reduce the fracture later on. The key here is to have weekly follow-up, because if you miss a follow-up, this looks really good, and you say, like the second X-ray, you look at it, and you tell the family that come back in 4 weeks. It is going to be malunited based on the third X-ray. So you have to have a weekly follow-up on complete fractures that were initially displaced. The other thing is, we didn't talk about it too much, is the wedging of the cast, that you can wedge a cast and can get a reduction. We do this.
We have all these cases. You want to reserve this for that, or you want to go ahead right now?
Yeah, no, we can reserve it. I didn't know that we had cases. And my last, I'll show you one more thing here is the bayonet. Okay, so bayonet is completely acceptable in children. Okay, so you see this position here. This is how the patient was treated. This is the first X-ray, and this is the X-ray after 2 years. So bayonet apposition is acceptable in kids. Same ones that we had the criteria for 10, 15, and 20, less than 10 years of age for boys and girls, 8 years of age. That bayonet position, as long as there is no significant angulation, as you can see in this X-ray here, you see that there is no angulation. It's just 100% displaced and shortened. These fractures would remodel very well. You can look at the final X-ray here at 2 years. So bayonet is completely acceptable in younger patients. Don't try to open reduce these fractures. As long as you maintain the alignment, these fractures would go on to heal okay. So these are just some points I wanted to share. I'm going to stop sharing.
Hey, Sheetal, I think I have your paper. We'll come back to your paper again. I have quoted that in. So let's get back here. So I think we are just starting with the interesting part of the story now. The complete fractures, the problems we face. So let's go from here.
Oh, I'm sorry. I thought that you were done with your talk. That's why I shared my screen. I didn't want to interrupt.
Fine. This is absolutely important. So I think you ended on a fantastic slide where I'm going to take over from now. So this 9-year-old male fell as a fresh fracture, went to an orthopedic surgeon, and who said that this is an isolated fracture, and I would like to operate and put a plate or maybe nail on a plate. So Sheetal, what would you do here? This
Um,
9-year-old male, fresh
my
injury.
initial treatment is close reduction for all patients. We'll try to close reduce all fractures, but the threshold is less for proximal fractures to intervene. So I'll try close reduction and see how it looks.
Yeah. So I want people to give in their idea. Whether you will just put a plaster on OPD basis, you will try a reduction here because it's an isolated injury. Will you be able to get a reduction under GA or not? And if you want to do a nail or plate, as this child was already advised. Carol, are you around?
A and B. People have some people A, some people B. Yeah.
Fantastic. So let's go further. So what happened here was that when I tried reducing, when I could get to the length, there was a significant angulation here. And if you can see here, there was an encroachment in the interosseous space in this view. So I left it like this. Right. And as Sheetal mentioned, this is the 1 month, 3 month, and 6 months follow-up. You can see that bayonet reduction of an isolated bone, even though significantly higher, has remodeled really well. And this is his functional development. So I think that goes without saying that bayonet is not something which should scare you. As far as your PRUJ is well aligned, and it may be slightly off, but it will come around, and you'll get an excellent movement in a scarless hand, which is very, very important. This type of patients will keep on coming to you with maybe adult trauma or joint replacement, so they will always remember you that you saved their pregnancy. Yes, Taral, your comments on this?
This reduction, yeah, this is fine. As long as the interosseous space is not encroached upon.
Yeah. So I think we need to remember that interosseous space is very important. It is as good as an intra-articular alignment you are trying to achieve, and in which bayonet reduction is not a problem as far as your interosseous space is good. Now let's go to this case. This child, 10-year-old male, son of my classmate who was a GI surgeon, and his father was our head of the department of surgery. So he came with this X-ray, and I said that this can end up in nailing. In nailing, if I do nailing, you'll get nice X-ray, nice looking X-ray. You go home tomorrow, everything hunky-dory, the result is assured. It's a simple fracture. But they said, no, we want conservative treatment. So this is after the conservative treatment, as Sheetal has advised, that we take a X-ray after a week's time, and this is the 1 week X-ray. 15-degree ulnar angulation and 3-degree radial angulation. I want you to answer this. You can answer ABCD or 1, 2, 3, 4, whichever you want. Yes, Taral, what is the verdict?
Most of them have said, one which is A, and some of them two. Yeah.
Yeah. So I think if you know that Sheetal has already mentioned that ulna is a subcutaneous bone, and any deformity here will be visible for a significant period of time. And at 10 years, 15-degree may not completely remodel. So best thing is you can do an innocuous procedure, which we have forgotten unfortunately, and which Sheetal already mentioned that you can try bridging. So this is the paper from their institute. A paper which was published, which people showed this was published earlier than that. That redisplacement rate following close reduction is 55% by first week and 95% by 3 weeks. So the message which this paper tries to give you is that if you take 1 weekly X-ray within first 3 weeks, then you are assured that the reduction is never going to sleep. So what should be next your follow-up when you're treating this conservatively is that you call the child at 1 week, 2 week and 3 week interval. Every week you take one X-ray. If you are maintaining the reduction, you can bring them back at 6 weeks or 8 weeks, depending upon your method of comfort, and then you will not have any displacement after 3 weeks time.
One
Which are the
question
high-
I want to ask again, Premal and Sheetal both, and what is the latest you will do attempt a re-reduction of a displaced radius ulnar fracture? So some fracture which you have reduced and has re-displaced in plaster. What is the latest you will attempt a re-reduction?
I think best would be to get it by 1 week, 10 days. Beyond that, everything becomes little difficult, and that there are chances of you going for open reduction becomes very high. People,
Yeah, in our paper, when we looked at re-reduction, we were able to do it successfully by about 15 days. We were okay. So I think up to 3 weeks I'll try, because for a shaft fracture, the callus takes about 3 weeks to form. If it's a metaphyseal fracture, then it's going to be difficult after the first 10 days. Up to 3 weeks I would attempt, but based on the level of fracture, whether I would just do a re-reduction or I would nail would depend, age of the patient and the level of the fracture. So I'm more concerned about proximal third fractures, which I would have a low threshold of nailing it in someone who is about 10 years of age. But if it's mid shaft or if it's distal, and in the OR, once we remove the cast and we reduce it and we check the stability and seems like it's going to hold, then I would just apply a new cast and not go with nailing. But up to 3 weeks, I've done it, re-reduced it.
I think that's fantastic. So up to 3 weeks, you can bring them back in the OT. But if you are supposed to nail after 3 weeks, I think you will end up in one of the bones having open reduction. But what is your comment on that, Sheetal? I've seen after two weeks, it's very difficult to get end-to-end alignment and get a nail.
Yeah, you're right that if you wait a little bit, it maybe, I won't say that you would need open reduction for all of them, but the nailing gets a little bit difficult the later you are. But up to 3 weeks, I've not, I would. So the reason to wait for that is because there is a chance that you can successfully treat it with close reduction. So, if you're following the patients, and the thing is that if you identify at 2 weeks that, the fracture is falling, at 1 week and 2 weeks, if there is progression of the deformity, you don't have to wait for 3 weeks. Then you know that the fracture would continue to displace. Then I would just, you also have to make sure the family is, knows about the possibility of surgery. The family is reliable that they would bring the kid back, because if you have someone who is 10 years and above and has a proximal third fracture and the family is not reliable, if someone makes a decision to go ahead and nail it, I would not think that that's the wrong thing to do, because you're avoiding potential permanent deformity or stiffness. So proximal third, I'm really we all are aggressive about it, but middle third and distal third, you can close reduce it at 3 weeks. Most of the time we would be able to close reduce. I'm not really concerned that the nailing is going to be difficult, and I make early decisions for the proximal ones.
So I think this paper from your institute clearly tells that children who are more than 10 years and proximal third radius fractures have high chances of redisplacement. So I think these are very subtle but very important points which are not very clearly mentioned in the textbook. That these are the patients you will be more careful. You may want to insist on to the parents that they come for follow-up, because follow-up is a big issue in our setup. This is the paper which Sheetal has already quoted. If you get a loss of reduction, you don't have to worry about it. A significant amount of that can be reduced back to significantly good alignment with excellent radiological and functional outcome without surgery. So plaster aging is already again mentioned by Sheetal that you can take that child on OPD basis under IITV, mark the level, open the fracture. This is a fiber cast which we have used. And you can use different wages. You can use any material which does not impinge on the skin, and then complete the plaster. This is how we could get a nice waging, 8 degrees post reduction. This is at the final healing, and this is the full functional recovery of the child. Yeah. So coming back to another problem, as I think we go back to what Taral said. This is a 3-year-old son of a pediatrician whose nephew was my resident. and he fell and had this fracture, and he was put on plaster on OPD basis. Sheetal, what would have been your way of treating this fracture?
Yeah, I wouldn't do anything different. For a 3-year-old, I would just any patient that comes to us with a displaced fracture, we would reduce it, but nothing more than that. So, and they're all done in the ED. When the patient in our setting, it's a little bit different. They all come to the emergency department. All of them get reduced if they have any displacement. They're all placed in a splint, and then that is when we see them is after 3 or 4 days. So nothing more than in a 3-year-old, it should be okay as long as you have a good AP and lateral view. Make sure that it's not a montagia. Make sure it's not there's nothing else going on.
So unfortunately, this child had only one X-ray, and after 3 months of this injury, he fell again. And this is where the question of Taral comes. When you have a minimally displaced fracture, you form less callus, and there is high chances that you get a refracture. So we'll go to the literature of the refracture. But one of the most important thing which this case tells you that you have to document radiological union before you ask the child to be fully mobile. What is your take on this, Shita?
Yeah, I mean, we still, I would agree. I don't see too many refractures in such a young child, in like a 3-year-old. But yeah, refractures can happen, for shaft fractures. You always want to counsel. You don't need to protect them after the fracture is healed. It can happen in the first year, most commonly. You don't have to protect them for that long, but you need to tell the family that anytime you have a diaphyseal fracture, there is a risk of refractures with these injuries. So the treatment, my initial treatment would not have been any different. It's just the counseling.
Yeah, so I think we should have had a lateral X-ray, as you said, that there could be montagia, and if you want to miss it, at least in your relative, you don't want to miss it. And this is the best thing we get. If you look at this cast, the cast is reasonably okay, but as the swelling subsided, he had angulation. Sheetal, what do you think here? I have this ulnar border is pretty straight, as I've used that arm board, and after some days with swelling subside, the arm has slipped. Do you get this things very commonly, or occasionally you do get when there's a significant swelling? Even though
you do get a little bit of movement of the cast over the skin as the swelling subsides. So there are a few ways of trying to minimize this. One is your interosseous mold that you can do. The second thing we always do is making sure that not just the ulnar border, but even the deltoid border is straight. So when you're putting these patients, make sure that you compress A to P. Like, a cast, though we always recommend it should never be tight, but you would get significant loosening in the proximal aspect of the cast. Like if you see them after a week or 10 days, you can basically put your hand in the top part. That happens commonly. So you compress them A to P, so that movement is decreased. The risk of having any compartment issues are less in your arm than in the forearm. So I would make sure that the deltoid border is straight. You have a 90-degree, because what has happened here is, if you look at the right side X-ray, is that the cast is in a good position, but the arm has slipped. You can see that this part of the skin, the proximal part, is just against the cast, and this part is away from the cast. So what has happened is that he has basically slipped under the cast. That means that this part has moved a little bit proximally, or the cast has slid a little bit distally, and that does happen. So to prevent that, there are a few things, especially in chubby kids who have chubby forearms, it's difficult to control it. So you do a supracondylar mold, or mold above, in the arm part of it, to prevent the cast from sliding down. Make sure you always have the cast around this part in the wrist, so it doesn't slide too much. And the cast should be a pretty good conforming cast. That means the casting, or the casting material, whatever you use, whether you use there are a few other tricks that could be done to prevent this from happening. One of my colleagues, he uses a mastasol, which is like a sticky kind of a thing on the skin, so that the cast doesn't slide off.
We used to use benzoin in earlier days. We don't get that now.
Yeah, you use something to make sure the cast doesn't slide off. But more important, I always use an A to P mold at the arm, at the top part of the cast. so that it doesn't slide off. But this is something that can happen, that the arm it's shocking. The arm is moving in the cast.
Great points, Sheetal, there. So we just waited and we got a nice alignment. That's 5 months later. So coming back to where refractures can happen. In one of the papers, they found that there are high chances of green stick fracture leading to secondary refracture when the duration of fixation was short or when adequate second injury is possible. See, kids are kids. Whatever you do, there is some chances that there will be refracture, and that's their physiology, and you cannot change that. But the good idea of even if you have a refracture, 14 out of 17 cases in this series were treated very well by conservative treatment, and loss of displacement is again shown in Sheetal's paper. There is nothing to worry about. You can go ahead and do conservative treatment for this fractures. So there is a paper which says that if in hyperactive kids and certain cases in which green stick fracture is there, if you use this type of splints, then you can decrease the chances of having a refracture. And this again a paper from Peter Newton, where they found that in proximal and middle third forearm fractures, there is a higher risk of refracture compared to distal third. They found that incomplete healing was more common in refractured cases, and small deformities at healing were not associated with any risk. Cast for 4 to 6 weeks should be given for distal forearm fractures. Additionally, removable splint was also prescribed to prevent refracture. In midshaft and proximal fractures, long arm cart should be kept for slightly longer period, up to 8 weeks was recommended, and splinting should be kept for about another 8 to 12 weeks, and you should restrict high risk activities like, people keep on jumping, people go on their hands, walk on their hands, jump on their hands, and all this should be avoided until you get a nice radiographic union. But see, these are series and these are retrospective studies, so it's very difficult to pinpoint for a particular fracture that which is likely to refracture. But you want to, before you fully mobilize the child, so suppose if the child is doing extreme sports, you want to ask parents not to send that child for those type of sports, so that refracture rate can be decreased. Anything you wish to add, Sheetal, here?
No, I think those are good advice. And these refractures happen in diaphyseal fractures. So you don't need to do the same things for metaphyseal fractures, whether it's a supracondylar fracture or distal radius fractures. Those don't have a refracture rate. So there you're fine. Once you see initial callus, you can mobilize them. But when you're having diaphyseal fractures, you need to wait for complete healing before you allow them to do full weight-bearing activities on their arm. So sometimes we would use a protective splint depending on how the patient is and how the profile is. And sometimes if the callus is robust at 6 weeks, we would let them go without a splint, but with advice not to do weight-bearing activities. So, I don't know how convenient or affordable the splint is, like a removable splint is in our setting in India. Here it's not a big deal. So if they want, if we think we need to protect them, we'll just give them a splint.
I think we have to make it made to order. It's not available freely off the shelf.
Right.
And it's an issue. That's why we don't see this being given very often. So this is the splint which this child was given after the removal, and he has done well. Now it is about 7-8 months. So again, as Haral said, another example of a simple fracture reduced reasonably well with a nice interosseous mold, and coming with a refracture because probably radiological union was not demonstrated, and child again fell on his arm. So refracture is one of the possibilities which you can deal with. This child was again given a plaster in the same position. He has unfortunately malunited, and he requires some surgical intervention in it. Right, this is his current situation. He has a significant restriction of left-sided pronation, comes to just mid-prone. And if you look at, if you trace this ulna, it will go to the radius. So this ulna is all the board and goes here. But if you look at this, you find that there's a cross union of radius. So this child cannot remodel so much and will end up in some form of surgery. Anything else, Sheetal, you would wish to say here?
No, I think just one that refracture is not an indication for surgery. It
Yeah.
happens, and you can treat them conservative, just like you treat the primary fracture.
So this child had a right forearm deformity, and undergoing came to me with a restriction of this. He had fell while playing 2 months back. He had shown to orthopedic surgeons. He was given 2 times POP, and 1 time and third time he had an osteoclysis. And this is how he came to me. And this is the child I again put him on splints because there was significant angulation and there was not enough callus to mobilize. Right, and this is not Sheetal, this already manipulated thrice. Would you at this point of time try and get him straight or you will
What
take
is
straight?
what is the age?
I think 6 years.
So he has been manipulated thrice, but so
Thrice.
is it redisplacing, or they were not able to get
No,
reduction?
I see. I didn't get the notes, and what happens here, Sheetal, is that sometimes when the patient has Mediclaim, everything is given to Mediclaim people, and people don't even have Xerox copies of that. So no
Yeah.
previous is available, no old papers available. So you don't know. Only the patient had 3 times given anesthesia, 3 times given plaster. He said that 1 time the bones needed to be broken. I felt.
I mean, if it's if the patient is say medically unfit, or there are social circumstances that you can't do something, then probably this would remodel because most of the deformity is in flexion extension plane. But I would, in our setting, if this was a scenario, I would at least reduce the fracture. So I would not accept this. But you have to look at patients' circumstances and what setting you are in, and
this
then
is already 3.5 months down the line from the first injury. This X-ray
yeah.
3.5 months down the line.
Right, but this is something which I don't feel comfortable accepting, like this much of angulation in a proximal fracture. So I would try to do something. Now, whether this patient had a refracture, seems like it because there is some callus there, or whether it's a
Yes.
non-union because of some other issues, whether it was open and then there is a non-union. To check everything, get a proper history, make sure that whatever information you can get would help you to make some decisions. Worst case scenario, what can happen here is that in a 6-year-old, this would likely remodel, so it would not be an issue. But I don't like to leave such deformities untreated when the patients first come to me. So my inclination is to reduce these fractures, and treat them as if they are fresh injuries. If they come at 3 months or 2 or 3 months with a refracture, treat it as if it's a new fracture that I've not seen them before, and make sure that there are no other reasons that the fracture has not healed. That means there's no infection, no other pathologic issues, and then I would reduce it.
So the child was absolutely normal. Child did not have any surgical intervention, but the parents were so fed up that they never wanted a plaster at that point of time. And I was also not very sure that whether I'll be able to correct this deformity at exactly that level, or I will be able to manipulate.
Yeah,
with this.
no. I mean, if you're talking about treatment like surgery, nailing versus casting, I'm okay. I mean, if someone nails this fracture, it's a 3-time attempt of close reduction. That is okay as well. I'm just saying that I would not leave it without treatment.
Yeah. So I just put that child in splint. This was at the time of presentation, and I think we'll just go forward. So this is after 1 month. Even after that, we continued giving him brace, and he ultimately united after 4 months solidly, reasonably well with 29-degree angulation. He still waited. I thought it will correct, but after 8 months, his angulation was 31-degree, and if you look at, he had a significant rotation and a pronation restriction on the right side because proximal third fractures are likely. Here also, if you look at, there is a significant ulnar bowing. This is a 1-year follow-up. Still, he has not remodeled, and there is an angulation like this. This is 20-degree radial angulation and 24-degree ulnar angulation. At this point of time, what will you do? So we have questions for candidates. It's a 1 year down the line. And now you can see the ulna is so bowed that you can see the straight, if you draw a straight line from ulna, it goes to radius, right? So this looks like a radius and this looks like an ulna. Karan, let me know what are the answers.
Number 4, yeah. Number 4 is working.
Yes, Taran, what would you do here?
So in malunited radius ulna, where your aim is to get more rotational movements, you'll have to do all what is required on table. So I would do radius and ulna osteotomy, and if required, release intraosseous membrane as well. If I don't get rotation on table.
Yeah, Sheetal, what would you do in this case? Significant ulnar problem, and a radius also is slightly mal aligned, but more less than ulnar.
Yeah, so it's not just the malunion of the bones that is causing it. Over a period of time, the interosseous membrane would get shortened and fibrosed as well. So releasing, just doing osteotomy of one bone, you can always do the osteotomy of the more deformed bone first to see if you can regain more motion. Your goal here is, besides the clinical deformity, is rotation. So you can, but it's unlikely in my limited experience, I would say, of treating malunions, because you don't want you don't want to end up in this situation, because you could predict very, very well initially that this was not something that we would accept. But if the patient just comes at this stage, being treated somewhere, and then you're treated, I would, do an osteotomy of the more deformed bone first, but would, as Taro said, would be prepared to do osteotomy of the radius and correct it. We have, we are kind of a little bit fortunate here to have some access to 3D models of these forearm fractures. We have the company called Materialize that they make, custom-made plates and jigs for osteotomies like this. So it is much easier, because you send them the CT scan. They would tell you exactly the level where you have to make the osteotomy. They would send you the plates and the templates with it. You put the plate on the bone, you make the osteotomy, and you fix the plate, and it would be back to the contralateral side. You have to send the CT of both sides. So you can, that has made it much easier for complex deformity planning to use custom-made, plates and jigs for each patient. But in our setting, probably, keeping all options open and doing an osteotomy would be the right thing.
So I think what the option which you said was shared in 2016 Ifics by Dr. Carly Wooler, which she showed that dizzy. So that we learned in 2016. We don't have access to that. So as you had advised, I did the osteotomy of the more deformed bone, and fortunately I got good movements on cable. So I went ahead and did only single bone artistic. This is a 5-month post surgery. This is improved cosmesis, improving motion. And I think we'll just keep the literature. I'll just share this. And this is about 1 year down the line. Terminal about 15 degrees restriction of pronation, otherwise he is good. And this is at the time of removal of implant. And I saw him day before yesterday, he fell again and he has a radius fracture. So kids will be great kids.
This is
I just
completely
gave him.
The radial angulation, I would not accept that. If you're doing surgery, you would do both. I would do both radius as well as ulna.
Yeah, the other point.
So I have.
Yeah, no, what I was making
Yes,
is not about this case, but anytime you are leaving a deformity, a deformed bone is more prone to refracture or than a straight bone. So if you're leaving a deformity and then you wonder why the patient has a refracture, one of the reasons is that the forces may be normal forces. It's just that a deformed bone cannot take too much forces. So there is higher rates of refractures and when you leave a lot of deformity. So just so that there is another thing that you want to keep in mind, that if you have a refracture, it's because the bone has been deformed.
For this patient, I had already discussed with the parents that will require osteotomy of the both bones. But I always wanted to do one bone first and go ahead and do it second. But they were quite satisfied with the functional and cosmetic outcome. So, and I don't have any experience of doing intraosseous membrane release personally. I've done in about some cases in VIC, in where you do muscle slide operation. Along with that, I've done that to improve movements. But in radius and the non-union, I think I have also experienced about 3 cases, And in 2 cases, I could get away with simple ulnar nailing with a good radiological, good functional outcome. I wouldn't say radiological, but I think radius non-union coming for surgery is not as common. As you said, in a limited experience, I also have a limited experience on that. So, Taral, you want to show this nailing technique? I think we can skip this case because we had a nice discussion. So this case can go. If time comes up, I'll show this case.
You want me to show the video, Premal?
Yeah, please. Yeah, I think that will be a good idea. We have spoken a lot about conservative treatment. I think it will be a good idea that look at the way of nailing. I think.
So what I'll do is I'll show the video quickly and a quick case where I've treated a malunited forearm fracture with a 3D modeling and reconstruction, the way Sheetal showed, he discussed. So quickly, I'm just going to share. 1 second.
I think we can have a question or two. Somebody, if he has any query, they can type in a chat box. We'll try and answer that till we get Taral's screen on.
Okay, so this video has been made quite some time back, but I suppose it's relevant today. This is almost 8 years back, 2007, this was done. So both bone radius ulnar fracture in a 12-year-old child. And some of the techniques, is this seen?
Yeah, very well. Yeah, Taral, very
Yeah.
well.
So, I use this side support for counter traction when you're giving the traction. So that saves one assistant. And we were all taught that time, and we still do it, is bend both the nails equally in a traditional ASIN fashion, and make sure that the maximum separation is at the fracture side. So used to use a dorsal approach for radius. Go down, expose the tendons because you don't want to have tendons being ruptured. The level is very important here. You have to be away from the physis. And using a drill sleeve, you make a small drill hole as an entry point. And with an awl, expand that entry point. And slowly, pass the radial nail. You can see here that, probably cause perforation on the other side. Go ahead with rocking movements. If you get stuck, back out and go again, but don't hammer. And for reduction, use the bent tip. So bent tip, you have to very tactfully use it. It's very difficult sometimes to get reduction in proximal radius in ulna because the bones tend to be narrower. More proximally go in radius, it is narrower. And for ulna, that time we used to use distal approach because, influenced by Dr. K. Wilkins, we thought that C-arm positioning was easier. But, sometimes it is very difficult because distal ulna is very narrow and it's very difficult to get a nail in distal ulna. You have to be protective of the dorsal branch of the ulnar nerve here because, you may end up damaging it. So you have to protect that. And this is the ulnar nail going inside. So again, people will ask question when you have both bone forearms, which will you nail first? And I tend to do radius first and then ulnar. And make sure that the interosseous space is maintained, and this can be done by rotating the nails well. Cutting the nail is an important job, and you have to leave the nail around 5 to 6 millimeter outside so that the removal of the nail can be easier. And I make the last part of the nail little irregular so that when you remove it becomes easier for us to remove the nail. So this is how the both nails would sit. Give a wash, close the incision, and then I protect these in a slab initially for around 2 weeks, and then give a functional brace after that till the time fracture heals, which is around 6 weeks or so. There are a lot of people who will probably not give a plaster, not immobilize, but I prefer to immobilize uh, in a slab initially for pain relief, and then give a plaster uh, till the time the fracture heals. So that any deviations, Sheetal or Premal, the way you would do radius ulnar nailing, please let me know. Yeah, you are muted.
Yeah. Uh, yeah. So, my preference for the radial snail is a radial entry. We have had some issues with tendon ruptures, the EPL rupture. And so uh, if you are going to be putting the dorsal entry nail, my recommendation would be to bend the nail 90 degrees and not leave it flush, because the tendons are around. Even if you have taken the entry from the bare spot, when you are moving the wrist, the tendon would have some excursion around the sharp or the irregular end of the nail, and you can cause tendon irritation or rupture. So we have, reported on 5 cases of EPL ruptures after dorsal entry. So my preference is to use a radial entry for your radius nail. The second thing is for the ulna. You can make a distal ulna entry, especially if you don't have help. It might be easier to just pull on the arm, and you don't have to manipulate it in different positions. But I've only done a few times. I usually prefer to come from above, from the side, from the dorsolateral aspect of the olecranon. So that is the second thing. The third thing is that I would also prefer to do the radius first, but I would not put the radius nail all the way up. I would pass the fracture and just leave it in the proximal fragment for about a centimeter or 2 centimeters. The advantage of doing it that way is you still have some mobility of the ulna, because once you fix the radius, and then I've had instances where I would not be able to reduce the ulna and I have to open it. And one thing about opening the ulna, it's not a big issue, but you have noticed in previous presentations that there is delayed healing. Sometimes it may take more than 6 months for the ulna to heal after an open approach. So it's better to avoid it. And one way to avoid it is to see if we can not fix the radius completely first, because then you have very less movement. So you can pass the nail in the radius and leave it just in about a centimeter or so. And I learned this trick from one of my partners, and I think that's effective. The last thing is I tell the families that the nails have to come out, and usually after 6 months I'll go in and remove the nails. So those are the few tips.
Premal, anything you would do differently? Of course, you use K wires. We saw that. Anything else? Yeah, unmute yourself. Premal, we can't hear you. Yeah. Premal, are you around?
Yes, sorry. I think I mistaken. Yeah. Okay, can you see my screen now?
Yeah.
Yeah. So this child, 6-year male, had this distal metaphyseal diaphyseal junction fracture of radius. Maybe you can say distal shaft radius, which is difficult to fix, as Sheetal has mentioned. And this is how the reduction was achieved. In 10 days time, this is how the X-ray looked like. So let us take an opinion. What would people like to do? Would you observe, remanipulate, nail, or plates?
So Premal, B and C are choices people are preferring.
So the surgeon was one of the members and he did the nailing. So any comments about the nailing? Anybody has any comment they want to make? The reasonably good alignment, poor X-ray. I can't help it because I borrowed the case little later on. It came to me.
Looks
Sir,
like
your
partial healing.
comments on this? Yeah, what is the comment, sir? I can't read that.
Looks like transfacial nailing and physis.
The radial is pretty long. The radius nail was bothering him, so the radius nail was removed. And after a few months, child came to me with deformity. And if you look at the X-ray, the radial growth plate had issues. So when I did an MRI, I found that the nail was done through the nail physis. And when I opened up, there was a big bar formation. I could get the all around physis seen, but this is how I ended up putting a fat graft and markers. Sometime I found that the bar resection was not successful. He had continued to have a radial shortening. Ulna started growing, and that is where very bad swelling had come up. And this is how the scenario was. So at this point of time, the function was reasonably okay, but deformity was bad. So this is how I tried to do. I did a shortening of ulna. I destroyed the ulnar physis and did ulnar shortening. And 5 years down the line, he has done well. He has a good radial alignment. Ulna is shorter than radius, and he has mild forearm shortening, but excellent functional results. So nailings can be tricky. You have to do it really well as thoroughly shown. And I'll just end my presentation with showing you what I did for the first case, which I received as a cubitus varus. Sheetal, one thing I have observed in 2 cases which presented to me after non-union of ulna after an interval of about 5 to 7 years, that the distal ulna becomes very thin in these cases. Any experience or any observation or in literature are you aware of? Or Taral, you have any experience with this? That the distal ulna becomes really hypoplastic when in long-standing non-union of ulna.
No idea. I would suspect some pathological fracture.
So this was in 2 cases I had, and there was no issue. This is the same case which I started the presentation with. It's a 2-year-old boy without any issues. Any comments, Sheetal, here?
No, I mean, these are difficult cases. You're right. I've seen, same with the fibula. I think the less weight-bearing bone undergoes more atrophy. So, it's an atrophic non-union. So you wonder not just about stability, but about biology as well. So, adding bone graft to it and then stabilizing it would be my preference. So I think you have done the right thing using a fibula or a cancellous bone graft.
I did both of them. So because there was a gap, so I distracted it on table with Jess and then did like this. So I still couldn't stretch it completely. So it's a 3-month follow-up, that's a 10-month follow-up, and that's its functional results. So as Taral recommended, to sum up for forearm fractures, plastic deformation is an entity which is special to children. You need a gentle, prolonged pressure. I think you will have to spend at least 5-7 minutes. See that you don't break the bone. In green stick fracture, I've been very happy with remembering where the apex is and putting the forearm in correct rotation. Radial crossover sign is something which I have learned about a year or 2 back, and after that green stick fractures are pretty less because kids are at home in India in most of this last 2 years. Conservative treatment is possible, as Sheetal has also insisted that in children about up to age of about 10 or 12 years, most of the times we can give them a conservative trial. If on weekly X-rays, if we find that the things are not doing well, maybe you can come in and either rededuce it, or in an older kid you can pass a nail. Your threshold for fixing any child should be less if you have a proximal forearm fractures. Because if you remember that in proximal malunion, there is a functional issue with rotation, while in distal malunion, it's more of a cosmetic problem. and less of a functional problem. So proximal malunion is not tolerated well, as it has been emphasized by all of us multiple times. You want to be very careful with upper third forearm fractures. When it comes to complete fractures, you can still get away with nice plaster. The plastering art is unfortunately forgotten. Most of my colleagues in my teaching institute, they hardly ever give plaster themselves. That's why my students don't learn it. Even if on my insistence, they are not very keen on giving plaster. Everybody wants to nail nowadays, which is not the correct thing. If you lose a reduction after a week, 10 days time, you can still salvage it without any anesthesia by doing a plaster wedging. Nailing is a good option in older kids and special situation. But whenever you do it as shown by Taral, you have to do it well and follow them till complete union. Document radiological union, especially if you have done an open reduction. As I have already shown, KYs work as just well as dents. I think in this American Academy POSNA meeting, there was a paper from half countries where they had compared results of intramedullary K-wire versus 10 nailing in fracture shaft femur, and they showed that both of them ended up in the same results clinically and union time. They just used simple K-wires as 10 nails with pilot and intermediate and lateral side. And whenever you are treating any fracture in child or any but fracture, as a matter of fact, be ready for occasional surprise. And I think they have taught you enough number of surprises for forearm fractures, and I think you all are good with that. So with that, I would like to end my presentation, and I would like to tell you that whenever you take a patient for treatment, you have to do a nice job, because I have great collection of this type of X-rays. So whenever you want to nail it, do it in a nice way as shown to you by Taral, and see to it that all the ends are correct and your nail is in a correct position, in a correct way. Thank you very much. Taral or Sheetal, you want to add anything, or if anybody wants any answer?
No, I think this was a pretty comprehensive session. I think you put in good cases.
So, I think there's one question by Santosh. He says that for KYs, do we need to make the tip blunt? What I've realized that if you cut the tip of the KY, it gets stuck more often than the pointed tip. So what I do is I bend it and use it that way, because once you cut it, it becomes rough, and to advance that, it becomes a little difficult. So this is some experience I had. So I stopped cutting the tip of the KY. But if you are using an implant which is not well, it's compared to 10, you will end up spending a little more time, but you will end up spending a lot of money. So I think we had a nice, excellent discussion and good cases from Sheetal, and I think I also showed you a lot of complications. So I think we can now go ahead and take a rest for Saturday evening. Enjoy our weekend, and meet. Karan, you want to take lateral condyle next week? So when you want to do that?
So lateral condyle, Sheetal, when are you free? Tell me next week. So we'll schedule it around same time. Is this time okay? Saturday?
Yeah, this time is fine.
Okay. So what I would request is, again, Premal, Sheetal, and Sandeep, send me your cases. We'll make a comprehensive presentation, so all cases are included, and we'll have more time for audience questions again during lateral condyle. People can ask more questions.
I think that's all from us. I think we can have a good Saturday evening, whatever is left of that. Thank you, Sheetal, for joining. I think it was. I think we all learned great points from this discussion. Thank you. So good night, everybody. So you can.
Thank you, everyone.
Sheetal, can you wait for a minute? We'll just have one or two discussions.
Yes.
My fellows can leave the meeting. People, so faculty સાથે કઈ interact થયું છે? I just wanted to.
No, I was really busy for some other, like the academy meeting had all the had to record everything for it because it's, you know, they have virtual and in live. I was busy preparing everything. Now I'm done with it, so I'll send out the dates are finalized
I think
because
next we'll have to shift. I think we'll have to shift.
because the academy meeting is academy meeting is August 31st to September 3rd or 4th. So that would be a little bit.
You can, so then we can do it from mid-September to mid-October.
Yeah, let's just decide on the dates. Then now I have some time. I'll write to everyone. But I was kind of a little bit busy last couple of weeks.
Okay, so I think our WhatsApp group પર વાત કરીને મેગસ કવાય તેના આપણે આવતા અઠવાડિયે થોડું we have contact.
Yeah, sure.
Okay, sure.
Okay.
Have a nice
All
day.
right. Okay.
Bye-bye.
Thank you. Bye.